Reminding you of your objectives, make sure that you go through the glossary of terms and understand what they all mean. We're going to talk about the things that are that happen when labor begins to compare true and false labor, um, what affects labor in birth, and what are some of the critical factors, what the cardinal movements are, and we'll get more into that later. The mom's response and the fetus response to labor and the birth. Um, what are the normal physiological and psychological changes that occur in all four stages? And it's important that you know what the four stages of labor are. And we'll talk some about pain, and we'll get more into that into chapters 14. You can look at this ATI video. It's about labor, and it's very good. So, the onset of labor, things that we know. It's very physiological. It has to do with the progesterone decreasing so that the uterus will then be stretching. And with progesterone decreasing, then we have an increased oxytocin level so that she will contract, and then the increased release of prostaglandins. Um, we don't really know why labor begins and what starts it. We just know that um, labor is influenced by the stretch from the fetus and the amniotic fluid volume. And as we said, the progesterone decreases. Estrogen now dominates to increase oxytocin. And then we have an increased release of prostaglandins. But there's lots of things that have to work together, not just one in particular. Um, there's really good reading about initiation of labor on page 456. Prostaglandins will cause her to contract even more, causing the cervix to begin to soften, and then we that is what starts the cervix to dilate. But we also have to have effacement, thinning of the cervical wall. The reason we have contractions, and like what I talked to you about last week, contractions for labor begin at the fundus, and that is to promote cervical dilation and to push the fetus through the birth canal. Okay, the premonitory or monitory signs of labor. These are very important to know that labor is here. Cervical changes, lightening, which means she's easier to breathe because the baby is getting engaged, and mom traditionally has increased energy level. This is what we call nesting when she starts getting the nursery ready. Bloody show, this is when she passes the mucus plug with a little bit of blood. Does this really mean that labor is coming right away? Not necessarily, but it is a sign of the onset of labor. Um, and this is because the cervix has become soft, it's becoming dilated, and there's a rupture of the little capillaries. That's why there's blood in it. She may find an increase in Braxton Hicks contractions, or there may be a spontaneous rupture of the membranes as onset of labor. Braxton Hicks usually last only for about 30 seconds. They can continue for as long as 2 minutes, but remember we said they are irregular. Um, and if she gets up and walks around and they go away, it's usually Braxton Hicks. Um, but if she's having issues or has questions, she really needs to call her physician. Spontaneous rupture of the membranes is whenever the membranes rupture on their own. Artificial rupture of the membranes is called an amniotomy, and this is whenever a physician, the membranes have not ruptured, she's in labor, and a physician would have to go in with an amnio hook, and I'll have one to show you in class, and he will rupture the membranes. Um, it's a good thing if they go ahead and rupture on their own sometimes, because we're not having to insert the amnio hook. But this is usually a sudden gush of fluid, but sometimes she may experience leaking fluid and it is still a rupture. But even though there is a rupture, there's still a production by the placenta of more amniotic fluid, so the baby can continue to be protected until it's delivered. After a rupture, it's very important to note that she is susceptible to an ascending infection because she no longer has that protective barrier. So the longer she's ruptured, the more increased risk she is of developing an infection. There's also a danger of cord prolapse because the baby is not fully engaged yet. And sometimes with this sudden gush of fluid, sometimes there is a cord that will drop. And so it's very important that we get her to call her health care provider so that she can be assessed, because if there is a cord prolapse, and we'll talk more about this later in the semester, runs the risk of the fetus getting into distress. We talked a little bit about this last week. True labor depends on the timing, how strong the contractions are, how uncomfortable she is. If there's a change in the contraction activity, or if it's enduring, if it continues, like getting up, walking around, she continues to have contractions. So, should she stay or should she go? Um, on table 13.1 in your book, on page 458, it's very good about the timing of true labor and what false labor is. True labor is regular, false labor irregular. Um, the contractions become stronger with true labor. She becomes more uncomfortable with back discomfort, and then it radiates toward the front of the abdomen. Contraction continue no matter position changes, no matter if she's walking around, no matter if she turns over on her side. She should stay home until her contractions are at least 5 minutes apart, 45 to 60 seconds, and strong enough so that a conversation during one isn't possible. But what she has to think about is, how far away do you live? Okay, you're going to wait until they're 5 minutes apart, but it's going to take you how long to get to the hospital? So these types of things need to be considered. The difference between true false labor, this is something good to remember. True labor, she's having contractions causing discomfort. This means the cervix is dilating. 511, every 5 minutes, duration for a minute, and this has been going on for at least an hour. That's a good way to help you to remember. This is just another graphic of cervical effacement. That's the thinning of the cervix. The picture on bottom left, that's a 2 centimeter dilated cervix. It hasn't thinned. Then 5 centimeters, 8 is just a little lip, and then 10 centimeters, it's very thin. That means she's complete and ready to deliver. The factors that affect labor and birth, they're called the 5 P's on page 458. The passage, the passenger, the powers, position, and psychological response. These would be the ones that we'll mainly focus on. There are another 5 that are also called the additional piece. Excuse me. The philosophy, like, are we going to do low tech delivery or high tech or high touch? Partners, patients, patient, and pain management, which would be comfort measures that we give. But the critical five P's are the ones that we focus on the most. The passage being the birth canal, which includes the pelvis and the soft tissues. The passenger, of course, is the fetus and the placenta. Anything that has to come through is called the passenger. Powers are the contractions. Maternal position and the physiological response. And I just mentioned the five additional factors that also affect labor, and we'll get more into those. The passageway. What makes up the passageway? The birth passageway, which the fetus must travel to be born vaginally. The bony pelvis makes up the passageway, which is the inlet, the mid pelvis, and the outlet. The pelvic shape. All this is on page 459 and 460 of your book. And the like I talked to you about last week, the pelvis and the pelvis shape will depend on whether she can deliver vaginally or not, because bones, the bony pelvis, the muscles move, the uterus stretches, but these bones do not move that much. And if she fell, broke a coccyx, or if the coccyx is in the wrong place, sometimes that can even cause her to not be able to deliver. And so that's why the physician really needs to take into account what is the pelvis shape. The gynecoid is the true female pelvis. The gynecoid is always the one, if there are no problems, it is the most favorable for her to be able to from. The anthropoid is common and mostly in men. Some women do have it. Vaginal birth is also favorable with the anthropoid. Some women have a combination of gynecoid and anthropoid. But the android pelvis and the platypelloid pelvis, the android pelvis is not large enough for a fetal head to descend through easily, and she would end up with a cesarean because the labor for this is very poor. The platypelloid pelvis is a little too, I call it more squished up. It's not long enough. It is kind of flat. The fetus can't align itself with the narrowest dimension of it, so the head can't come through very easily. So anyone with this type of pelvis would end up with a cesarean section as well. On page 459, you'll see the division of the false and true pelvis, where the inlet is. Why is the mid pelvis so important? You'll need to know those things. The outlet, like I told you, it's unyielding. It does not move. So this is why pelvic measurements are so important. And the false pelvis, that is where your iliac bones are. And of course, you know where the wings of the base of the sacrum are. Here again, gynecoid is favorable. Android is not. It is favorable. Why is android? I'm getting myself confused. Android is not favorable. So gynecoid, anthropoid are adequate. Platypelloid and android are not. And here's just another picture. This is the same as what you see in your book. And you can see why I call platypelloid kind of squished down. It's not rounded enough for a baby's head to go through easily. Those two little bones that you see on the sides, those are called the ischial spines, and I will talk to you about that in a little bit. Ischial spines is where we measure what station the baby's head is in, so we can determine if they're ready for mom to go ahead and push for the baby to be successfully delivered. Soft tissues are another part of the passageway, which include the cervix, the pelvic floor muscles, and of course the vagina. And these are all areas that through effacement the baby's head is able to go through the cervix as it thins. And the pelvic floor muscles help the baby to rotate, and we'll show you some pictures and talk about rotation and transition in a little bit. The vagina, the muscles have to stretch, they have to expand for the fetus to pass through. All right, you can read your case study and answer the questions. It's very important to take a prenatal history. So just go ahead and read through the case study and work through that. The passenger. Who is the passenger? Of course, it's the fetus because it's going to be passing through, and at the end of labor, it will be the placenta. The fetal skull, the fetal attitude, the fetal lie, presentation, position, station, and engagement. All of these things are very important, and they're included starting with figures 13, 3, 4, 5, 6, 7, and 8. On 461 is where it all starts. The skull is the first presenting part that does get compressed, and so it has to be in such a way where the sutures in the head can move and get compressed during birth. Sometimes the fetal skull will become elongated because of the overlapping cranial bones. This is called molding. And so sometimes with the molding, some fluid can collect. It's called caput or blood, which is called cephalohematoma, which distorts the shape of the head a little bit, but it does go away. Just like Miss Arnold was talking to y'all about whenever we were talking about fetal newborn assessment. And all the suture lines and sutures and where the fontanelles are, you can see all of that on page 461 in your book. The sutures allow for overlapping and changes in shape, and this helps us to, whenever the healthcare provider or the nurse is conducting a vaginal exam, which always, always, always must be sterile, helps us to identify the position of the head. The fontanelles are the intersections of the sutures, and they help us to also identify where the head is and where the position is. The diameters on page 424, the frontal, the mental, the brachmatic, and the parietal lets you have an idea of where all of the different diameters are and where we'd be measuring. And here's a big picture of it. Occipital goes from the lower jawline to the back. Parietal, of course, is in the back, top back. Occipital is at the base of the skull, and anterior is on the front, of course. Temporal is on the sides of the face. Fetal attitude. What is the attitude of the fetus? Where is that head? All right, picture A is flexed. This is the position the baby should be in for ease of delivery. Extension is B. They can still be delivered, but you can see where the baby's face is. We have to be more careful so that we won't do quite so much damage, but an attitude of flexion is what we're looking for. And that's when the smallest part of the diameter of the head will present and makes it easier. Fetal lie. How is the baby situated? Longitudinal is picture A, which is also in your book on page 462. Transverse is whenever the baby is essentially lying sideways. It's the relationship of the long axis, which is the spine, to the mother. Longitudinal is the most common. There's transverse, and then there's oblique, but you don't have there's not a picture of the oblique. Longitudinal is the most favorable for mom to be able to deliver vaginally. A transverse is when the fetus is perpendicular to the mother, and in an oblique, the long axis of the baby uh, is at an angle to the bony inlet, so you can't really feel where the fetal head is or anything. And um, it's usually during the time when the baby is trying to turn to a engaged position, and that's usually oblique. But if they stay in this position, or if they stay in a transverse position, she's going to have to be delivered by a cesarean section because you don't have an engaged head, or you don't have an engaged hiney. And we'll talk a little bit about breech in a second. Presentation: cephalic, vertex, a military, a brow, or a face. This is on 13.7 in your book on page 463. These can all be delivered vaginally. Uh, Naturally, you rather have a vertex, which is the picture A in your book. It's a little bit easier. B is military. It's got the you see where the face is more straightforward and coming straight through. The brow can still be delivered, but you can see where it would be a little bit more easy for some injuries. And face. These can all be delivered. Now, breech presentation is either called frank, full, or complete, or footling, or incomplete. You can see these on page 463 down at the bottom. These are all when the baby's head is not coming first. And the other delivery is a shoulder, with shoulders coming first instead of the here's some other pictures for you for a cephalic passenger. This is the head first, um, where you've got complete flexion, a vertex presentation. That's the one on the far left. That's the one that's the most favorable. Military presentation has some flexion. Poor flexion is the brow presentation. You can see that. And then a full extension is usually with a face presentation. And here's some pictures for you of the breech presentation. You can see where this is a little more difficult. There's very few physicians in town who would still be willing to deliver a breech vaginally, and you can understand why. Breeches are usually associated sometimes with prematurity or placenta previa. That's when the placenta adheres close to the cervical os, or some type of uterine problem, um, or some types of congenital issues like a hydrocephaly. A frank breech can be delivered vaginally, but a complete footling and incomplete breech usually has to be cesarean, and you can see why you would do damage not only to the baby but also to the mom. I'm looking to see if I have a good picture. Here we go. The shoulder passenger, this is used also termed shoulder dystocia. It's where the scapula is coming down first, not the baby's head. Um, this is whenever you have shoulders that come first, the head is tucked inside. Um, this usually happens sometimes when the mom is pushing and the head is going to slowly extend, but then the head goes back up into the vagina. This is called a turtle sign, and here comes a shoulder. Uh, the fetus is usually transverse, and sometimes this happens with a prematurity. She's had multiple births, so her uterus has stretched and to the point that the baby doesn't get engaged very good, or some type of anomaly. Usually we have to do a cesarean uh, if we can identify a shoulder dystocia before labor begins. Unfortunately, sometimes a shoulder will appear during the birth process. The baby is always engaged, and sometimes we have to go ahead and deliver if the baby has already become engaged and we notice that there's a shoulder dystocia. And um, we'll talk more about that when we get further on into chapter 21 on how to deliver a shoulder dystocia. Mechanisms of labor. This is just something to help you remember if it helps. Descent, engagement, flexion, internal rotation, extension, external rotation, and expulsion. Darn Egyptian fools in rural Egypt eat raw eggs. The baby has to descend, head gets engaged, a good flexion so that there can be a rotation to get the head in the right spot, extension to push through, external rotation, and expulsion. Just like that little video I showed you guys the other day. The position. We need to know where the occipital bone is because this would be a vertex presentation. The mentum, the chin, that's a face presentation. The sacrum, S, is breech. Scapula, the acromion process, is a shoulder. On page 464, it gives you the mnemonic for that. The three-letter abbreviation for the identification of the presentation. If you look at the bottom of that page, right occiput posterior is ROP, left occiput transverse is LOT, left occiput anterior is LOA. That means the occiput of the baby's head is more anterior to the mom, and it's on the left side, mom's left side, not ours. LOT, left occiput transverse, the baby's head is more to the side to side, pointing to the left. Right occiput posterior, you can see the occipital bone of the baby's head is more posterior to the mom. That's how it's determined. And that's what you'll see charted. You see where the symphysis pubis is, that's considered anterior. You see where the sacrum is, that's considered posterior. Left anterior, left posterior, right, etc. And so we determine on where the occiput is to determine the presentation. And this is just another picture of all the different positions the baby can be in. Fetal station. When the fetal head gets down to the ischial spines, that's considered zero station. Anything above, up into the false pelvis, where the baby's head is still floating, those are considered negative station numbers, -1, -2. After the ischial spines, after 0, is positive all the way out. And this is just a little thing to help you remember about fetal station, the relationship of the fetal head to the mother's pelvis, where the ischial spines are, I'm at 0 from here. It's all positive. That means I'm on my way out. And you'll see this documented on what station the baby's head is in, how dilated she is, how effaced she is. Engagement. Presenting part has to reach at 0 station. Floating means there's no engagement. The presenting part is movable up into the pelvic inlet, kind of floating around up there. Cardinal movements of labor. At first, there's engagement of the head, descent, and flexion. Then, internal rotation, extension to begin, external rotation where the shoulders rotate, extension is complete, and then expulsion. This picture is a little confusing because it goes from left to down to right to down. If you look at page 466, it helps you understand it a little bit better. Descent's the downward movement of the fetal head until it's in the inlet. And this is brought on by pressure of the amniotic fluid, pressure of the fundus to the buttocks or the head, depending on which is the part located in the upper part of the uterus. Contractions, extension and straightening of the fetal body. Descent happens all during the time of labor and it ends with birth. So mom is going to be very uncomfortable. Flexion, as the vertex meets resistance from the cervix, the walls of the pelvis, or the pelvic floor. Internal rotation, and then extension, and then external rotation, and then expulsion. What bothers me about this picture is you start extension and then you've got to go back up to the picture where it says external rotation, if you understand what I'm talking about. So that's why this picture is a little confusing to me. So it goes left to right up at the top, then internal rotation, then extension, then it goes up to external rotation, restitution, external rotation, shoulder rotation, extension complete, and expulsion, if that helps you to have a good idea. And this is just different positions again of the fetal eye. Excuse me. Now to the powers, the contractions, which are the primary stimulus, power in the labor. These should be strong enough to cause complete dilation and effacement of the cervix, and if they aren't, a lot of times we have to do something else. Sometimes it's just mom is so tired she's just not strong enough anymore. These contractions cannot be controlled because they happen regardless of whether or not they're spontaneous or induced. Spontaneous contractions with the 3 parameters of the contractions. On page 468, it gives you a really good picture of the 3 phases of a contraction, and this is what we're looking for. And on the fetal monitoring strip, which we'll talk about in class for chapter 21, we'll look at contractions in relation to what the baby is doing so that we'll know if the baby is oxygenating well or doing okay. The frequency, how often the contractions occur, we measure it from the beginning of one to the beginning of the next. The duration, how long it lasts. and that is from one contraction to the end of that same contraction. That's why it's important to know the increment, the acme, and the end, or the decrement. Intensity is how strong the contraction is. We can either manually put our hand on her abdomen or put in what's called an intrauterine pressure catheter, which is an IUPC. We'll talk more about those later. Um, and if we're having a hard time keeping her on the monitor or seeing what she's doing, sometimes we'll have to put one of these in. Position. Uh, there are a lot of myths about the different positions that mom can be in. And there are myths about holding her head up above her head may cause the cord to prolapse, which is not true. That they have to conserve their energy, or they uh, we can't let them ambulate whenever they're in labor. Um, Only the healthcare provider can make the decisions. There's a lot of different things that are going on now with labor and birth. We're still very medicinal, is what we talked about last week, where we want to be in control of moms instead of letting them be in control of or be a part of the labor and birth. We're still laying them flat of their backs during labor, and we need to help them be in positions of comfort on page 468 and 469, as long as it's safe for the mom and baby. Now, sometimes if their membranes are already ruptured, we want to take care with letting them get up and ambulate too much, especially if the baby's head is not engaged yet, because we'll run the risk of prolapse cords. Of course, we always want her to be in more of a convenient position for us, and so what's that? Flat of her back and not in anatomically correct positions. So we need to make sure it's safe for mom and baby and make her as comfortable as possible. Moving around is beneficial. Uh, Knee chest position. Using the labor bars. She can sit on the birthing ball. There's all different types of things that can be used as long as it's safe to do so. All of those are on page 469 of your book. Psychological changes. It's very important that we are clear, concise, give her clear instructions on what's happening and what we're doing. That we give her support, that we make sure we take account of, does she have people that are going to be there in the room with her, or is she going to be all alone? She doesn't need to be alone. We need to help build her self-confidence. We need to build her trust. We need to have a non-judgmental attitude. Um, we need to help her to maintain control over her breathing, because we're even if she has an epidural or some form of spinal, um, she is going to have some labor pains before we're able to help her with those measures. We need to as much as possible, because we want her to have a positive birth experience. We always hear people give horror stories, and it doesn't have to be horror stories as long as everyone has a good line of communication going on. Things that are going to happen physiologically, and we're expecting these, and we need to explain these to her in terms that she can understand. She's going to have an increased heart rate, increased cardiac output, and during contractions, increased blood pressure. And why is that? Well, number one, her cardiac output is increasing because her heart rate is up. So naturally, more forceful blood pumping is going to cause pressure to go up, but also she's hurting. She's going to have increased white blood cell count but we're not looking for it to be so up that it's potential for infection. Um, what else? Increased respiratory rate and oxygen consumption. So we want to make sure that we monitor pulse oximetry because we want the baby to be oxygenated. So sometimes we'll need to give her some oxygen so that the baby is oxygenated well, and this is by a non-rebreather mask with 10 liters per minute, not an oxygen cannula. She's going to have decreased gastric motility and food absorption, so usually all we're going to let her have if she is in labor is some ice chips, nothing to eat because with decreased motility, we're increasing the issue of her possibly vomiting, and we don't want anyone aspirating. And she'll have decreased gastric emptying, so we don't really want any food in there. Sometimes she'll have a slight temperature elevation, but not over 100.4. Muscle aches and pains, increased basal metabolic rate, and her blood glucose will go down a little bit. These are all things that are expected, and we're not expecting the blood glucose to drop like a whole lot. All of these things are on page 473 of your book, with explanations and rationales of why these things are happening. And most of them are related to the trauma of the vaginal birth or because of the stress of the labor. But after the delivery, mom should be, her body should adapt back and start getting back to the normal. We expect fetal heart rate accels and slight decelerations. These would be called early decelerations. Um, we would expect a decrease in circulation and perfusion because of the stress of labor. We would expect an increase in arterial carbon dioxide pressure because of the squeezing of the labor process, and this is why mom sometimes we're putting her on oxygen naturally. Decrease in fetal breathing movements because the chest wall is getting squeezed in the birth canal. Decrease in fetal oxygen pressure and decrease in partial pressure oxygen. Um, we're wanting to make sure that the baby is tolerating labor, so the mom would be on a fetal monitor, whether external or internal. And if the baby is healthy, they're able to compensate for all of these changes in perfusion and circulation. But this is going to help. All of these changes help the baby in preparation for taking its first breath once it's out into the real world. And that's what we're watching for. Stages of labor 13.2 in your book on page 474. The first stage is broken up into three phases, and this is what students often get confused of on their paperwork, because our paperwork is very explicit with the different phases of the stages. But a lot of times in the hospital it's a little different because they're in the first stage. That's from uh, 0 to 10 centimeters, but they don't break it up into three phases, but for our purposes we do. True labor is the first stage to complete cervical dilation. Um, it's the longest of all stages because she could be in the first stage of labor until she's 10 centimeters, many hours, depending on if this is her first pregnancy or not. And you can read in your book how long each phase can last, and of course, these are generalities. The second stage is from 10 centimeters dilation to the birth of the baby. The third stage is the placental separation and expulsion. And of course, the fourth stage is 1 to 4 hours after the birth. And this is when the maternal physiological adjustments begin. And it's considered the postpartum, beginning of the postpartum period. You can read of all these transitional phases, all the things that go through each stage of labor. It's important to have an idea of what occurs when. Pushing is what occurs during the second stage of labor until the baby is. You can read the case study and go through it and answer the questions. Okay, signs of placental separation. This is often sometimes confusing for students. I want to see where I am in your lecture because sometimes I get cut off. And now we're going to talk about factors influencing pain during labor and birth. Um, and we're going to talk more about pain in chapter 21. But there's physiological, spiritual, psychosocial, cultural, environmental. Our priority, as we've said before, we want a healthy mom and a healthy baby. So the challenge is to have the right combination of pain management, whether it be medication or whether it be positioning. We want to have the right combination of all of those things so that she's comfortable. Mothers cannot effectively push and cannot effectively deliver if they are squinching up and bearing down with pain so intense that they can't concentrate. Um, and it depends on what mom's definition of pain is. Some women handle pain better than others. What are her spiritual beliefs about pain medication? What do we need to educate her about to help her to understand she's not going to be a drug addict if she decides to take an IV push of something or an epidural? What are her psychosocial adaptations? Has she been on drugs before? Because if she is addicted to social drugs, sometimes we are very limited on what we can give them. What are her cultural beliefs? What types of customs does she have if she's from a different culture as far as pain during labor and birth? It's very important to find out those things. Any type of environmental concerns, um, any kind of occupational hazards that she has been around that might affect what we can possibly give her. Has she been consuming some types of herbs, some types of different diets? So we need to know all those things, which is why a good prenatal history is good, and we need to have those records over there so that we can give them the best care ever. Realizing sometimes you do have an emergency situation that comes in, you have to do the best you can. Ask the main important priority questions first, especially has she taken any types of drugs? What types of drugs are they? So that you will know if you can or cannot give her some types of medications. All right, that's it with chapter 13, and we'll talk about chapters, whatever the chapters are that we're supposed to talk about, ending with chapter 21 on Tuesday. Thanks.